The future of healthcare innovation begins with powerful conversations. JV EdTech Medivation, in collaboration with Power of Knowing Forum, proudly announces a healthcare podcast series focused on the future of healthcare innovation. This next-generation podcast series explores hospital systems, medical technology, AI in healthcare, and innovation, bringing together experience, expertise, and meaningful dialogue. The series delivers real-world, actionable insights from global healthcare leaders, moving beyond theory toward practical implementation and impact. Beyond theory, this podcast series focuses on real impact by bringing actionable insights from global healthcare leaders, doctors, and technology innovators. The conversations cover key areas such as AI in healthcare, telemedicine, smart hospitals, and emerging medical technologies that are shaping the future of healthcare systems worldwide. Medical schools, healthcare institutions, students, faculty, doctors, and healthcare professionals from India and across the world are invited to be part of this journey. Backed by Power of Knowing Forum's 300-plus episode legacy and aligned with global standards, the series offers structured, easy-to-understand learning for both executives and learners. Our shared vision: make healthcare knowledge accessible, innovative, and impactful. Encourage global collaboration in healthcare education and technology. Empower the next generation to listen.
Very good evening to one and all. What if a medical breakthrough isn't discovered in hospital but decoded in data? Welcome to From Molecules to Machine in the new age of AI and a precision pathology, where biology meets algorithm and microscopes meets machine learning. For over a century, pathology has relied on the trained human eye, interpreting cells, tissues, and the molecular signals to diagnose disease. But today, artificial intelligence is transforming that landscape from decoding genomics mutation to detect the subtle cellular pattern invisible to human. We are entering to the era where machines don't replace the pathologist, they amplify them. In this episode, we explore how molecular biology, computational power, and AI driven diagnostics are converting to reshape the precision medicines. How do the neural network interpret the tissue slides? Here, can algorithm predict disease progression before the symptoms appear? And does this mean for clinician, researcher, and patients? Today, let me take this opportunity to introduce a very dynamic personality for the episode 3 JV Tech Medovation and the Power of Knowing You Forum in collaboration with the Healthcare Podcast series. We are very happy to announce we have Dr. Ravi Gaur, a medical advisory committee. He of OnQuest Labs, New Delhi, and founder and DRG ex Unibug Path Lab, ex-chairman and medical advisory board for the Unipath Specialty Laboratory, Ahmedabad. He also serves the ex-principal advisor, Spice Health. He also has a 30 plus experience in pathology, healthcare management. He has set up the many institutes with the pathology, molecular special labs, high-tech driven, and the hospital-based chain and the independent labs. Much more on this. I believe that getting technologies in India that change the train and which is as shown by Dr. Ravi Gaur. Welcome.
I think my pleasure to be has been created where we are getting the newer things which are actually of great use and probably integrating the what we were doing today and what's like till today probably and the future together. And that's probably I must congratulate you the kind of great work you guys are doing. So it's my pleasure here. So I think I look forward for the discussion, and I think I'm sure something nice. And when we talk about molecules, the molecules are always excite me, and I'm sure machines and molecules together, there'll be great synergy together, and probably something what we all hope for: better diagnosis, early diagnosis, better outcome, and better healthcare. Thank you.
Thank you so much, Dr. Ravi. It's indeed pleasure. A person like who come from an expert, setting up different diagnostic labs and the molecular, as it you say, it's really interesting subject of yours. Here we start with the podcast with the first question. How do you envision diagnostics evolving over the next decade from laboratory medicines to an intelligent decision ecosystem? Over to you.
Very right question. I think I must say that till about 2 decades back, pathology was always like one of the sidelines. But I think almost last 15 years, or maybe most, actually, especially during COVID and post-COVID, pathology diagnostic has become a pilot because everything moves around it now, and that's the change. You see changes happen, and especially I think we learned late, but I think COVID showed us the way, like how diagnostic is important. Let me give you some data. India performs roughly about 3 to 4 billion tests annually. Now, if you look at the market size, I will say that you have about 20 billion US dollar market size in India, which is going to double in next decade. Now, you can imagine the kind of the growth diagnostic industry here. Now, if you look at other way, how diagnostic, but always was kept behind. Diagnostic was always behind the microscope. One lab is one corner of the hospital. Nobody was showcasing it, but today things have changed. Because if you look the real depth of diagnostic, before a patient feels pain, before symptoms whisper its warning, there is a conversation happening within a body. That is what we all know. In a drop of blood or a fragile cluster of cells, all the molecules which carry the truth. Not many can see, but diagnostics can hear it, see it, and probably explain it what's happening. Now, for decades, diagnostic has been, I mentioned, working in the background and decoding life and guiding 70% of decision. To 70% of clinical decisions are based on diagnostic. If you look at the expenditure, not more than 3 to 5% of the entire healthcare spend is on diagnostics. And that imbalance is critical and opportunity too. Now, this is a change what we are seeing today. Now, let me explain it. Today we are moving from an isolated test reporting to an integrated decision intelligence. Now, let me give you a very simple example. Today, when we go, we have something, the report says this is your hemoglobin, 15, 12, whatever. This is what the report says. But now I think the integration is happening. What I definitely see, and it already happening some places, but probably another 5 years, you'll have a report which will say, okay, this is your 5 year anemia risk prediction. This is how the hemoglobin will go up and down. And these are the intervention pathway, how to improve upon it. That means what is happening? There's no from the isolated test reporting to integrated decision making. This is exactly what we are envisaging to. We have and similar thing happening for say anemia risk protection is one part. Probably the hospital readmission risk again will be based on diagnostic. Patient is discharged and come back. Will he come back or not? Will he come back after 2 days, 10 days, or is perfectly free? I think the prediction can be done by diagnostics, biomarkers done well, use technologies, and integrating together. Otherwise, they all work in isolation, in silos, and is all fragmented. Sepsis, early onset of sepsis, which can be predicted. So once you have all this, I think this is where I think we're developing a intelligent decision-making system, and technology is enabling us that. Now we are instead of decision ecosystem where lab data integrates with electronic medical records, wearable data, genomics, population analytics, everything is now getting integrated. And probably we have entered in a you can say at an infection point. That's the infection what we're having. What? Like the massive disease burden, the chronic disease, NCDs are growing very, very fast. Infection, which we thought we have won over them, they come back. COVID has shown us, be careful of the infection. It can predict. Then parallel, the government is also working. Everybody is working on the digital public infrastructure. That means like Ayushman Bharat Digital Mission (ABDM). They're trying to put everything, put in data together. Now, if we use it wisely, do it in the right way, entire data together, disease burden, I think India can be the leading in the world, especially when it comes to understanding the disease and taking care. So I definitely feel that there is a big hope, big opportunity. Things were already there, but I think pathology is strong today. And I think diagnostic, not only pathology, in fact, entire diagnostic, pathology, biochemistry, molecular, genomics. I think this will now drive the treatment, and not only for the treatment part, but prediction, predictive, prognostic, therapeutic, anything for that matter. That's my thought.
Oh, absolutely, very well said, Doctor. When it comes to, as you mentioned about the COVID possibilities, and of course, over a decade, we have seen there's an integration of genomics, imaging, wearables, and there are more longitudinal health data. And of course, when you talk about the lab, which is no longer just generate the report, but of course, it is there for the clinical intelligence streams, and the diagnostic will overcome the healthcare system too. Okay, moving to the next question. When I talk about the from molecules to machine, the pathology began with morphology. Today we speak about the molecule, algorithm, and the machines. Are we witnessing a paradigm shift or an expansion of the same science? Over to you.
Definitely, I'll probably say this is just isn't just a paradigm shift. It is actually the precision expansion. I think we are expanding it much, much more precise. The precision medicine is driven by this. Now, if you look at this, the pathology started with morphology you mentioned. That's it. Then came biochemistry. Then came the tissue biopsy, immunohistochemistry. Then came molecular diagnostic, genomics, and now we have AI-based image analysis. All this is happening today. So this is not a replacement of science. The expansion of what was there. Technology enabled us to look into more. Earlier, we used to see cells under microscope. Today, we can not only see cells, we can talk about proteins, proteomics, DNA mutations, all genetic can be seen. What are the gene look like? We can talk about tumor microenvironment. We can talk about digital pixel signatures. I think the NGS, which was like which was very expensive, whole genome sequencing cost had come down to almost by 90%. Mut, multiple mutation panels. Any gene which is mutated, not only probably in the oncology, of course, is already taken up first stage, but many other lifestyle disorders, biology, everywhere we can see this. Which drug is going to happen because of the various biomarkers, proteins, genomics, environment put together. So, then similarly, in biopsy, slide imaging, who can imagine that living without a microscope? Pathology labs cannot work without that. Today, we are getting second opinion. Whole slides are being it caught up. Radiology was came much earlier, but pathology is today. Entire whole slide scan imaging. You can send the image within 7 minutes, 10 minutes. It can go internationally, abroad, wherever it is. Maybe who are the second opinion or third opinion, the best of super specialists. Now, artificial intelligence actually can actually know the quantify the tumor, which how much tumor is going into lymphocyte count. What is the mitotic index, which all can be seen today. And this is again what molecules will actually straight away we've gone much deeper and understanding how what molecule talking about. So this is not basically say again here. We are not abandoning morphology. It is we are digitizing that morphology. And I think it's definitely a paradigm shift. And pathology evolved now from seeing cells to decoding complexity. No doubt, future is right here. And I think we're getting more precise diagnosis, better treatment, and of course, better health outcomes.
Very well mentioned. I must say, an institution such as a Mayo Clinic have integrated the digital pathology and the computational tools not to replace the science, but to enhance the resolution and the reduce variability. So, definitely the core principle of the science, which actually says that the pattern recognitions and the correlation and the interpretation. So, amazing insights, Dr. Ravi. Moving on to the third questions, where AI versus human intelligence. Now, will AI redefine the role of a pathologist from interpreter to supervisor, or will human judgment remain irreplaceable?
I'll straight away will tell you this. AI can never replace pathologist or a it can never come what may. But pathologists are you who do not use AI. They probably might be replaced by people who are using AI. That's fundamental. Like I'll say, because how will I probably before I go on how AI helps in diagnostic, I'll probably say AI. I've always been talking about it various forum. AI also stands for artificial intelligence. AI also stands for intelligence. So if you're using and AI is augmented intelligence, this is various nomenclature or whatever way you can think about it. If you use your actual intelligence while you with artificial intelligence, that means actual intelligence, use actual intelligence while using your artificial intelligence tools, it can be a awesome intelligence. That's again. If you don't use it, it can be a awful intelligence. So what I'm trying to say is that human pathologists is have to be there in between. Otherwise, things won't work. So it can never replace. That's one. Now AI can happen. What happened? Like India. Look at India. There's such an uneven distribution of pathologists or diagnostic people. 250,000 labs. We just have about 20,000 pathologists, maybe another 10,000 biochemistry and microbiology of the people. How will it work? And that too uneven distribution concentrated in top 20 cities. Now, this is where I think, we need to look into it. AI will help here, deploy it here. Pattern recognition at scale. You can always see the pattern much because human mind is a fatigue kind of a thing. Because I think at some point in time, you can always say biopsy, 40 slides, 35 slides. Suddenly, after that, your day goes off. AI can continuously keep working. So free screening and quantification. It's subjective. Say, okay, it is 2 plus. Somebody say, no, you're 2.5 plus. Somebody says so standardization, quantification. AI can take care, and especially when you talk about it is very relevant, especially when immunohistochemistry and breast cancer. We have HER2, ER, and HER2 positivity. They require percentage, and because of the percentage, the treatment and outcome it depends. AI can definitely help on that. Rare anomaly. The human mind has not seen anything. Now, if they are not seen, you cannot be able to identify. You can't say something abnormal. AI probably thought well, machine thought well, probably can identify the rare anomalies. Human and intelligence will always remain, I mentioned, because it can actually be, ethical reasoning. When the questioning will happen, probably AI will not be able to. I think reasoning will come from the human mind. Correlating the clinical ambiguity. Whenever there's ambiguity, other places correlates well. I think the human mind will talk to each other and release that. And that ultimately becomes, again, an artificial intelligence. And the responsibility overall, it still lies with the human pathologist. So, like these are a very important point of it. So, what I am there to say that a pathologist today just may not, from the microscopic operator or just operating a microscope or just sitting behind the microscope, he has to come the front. And the definition of microscope pathology is going to be defined as a clinical solution provider because they have to integrate a diagnostic strategist. How do this decision helps? So again, I repeat, the role of pathologist is not a slide reader anymore, but a diagnostic strategy, and they can never replace. But yes, use the tool as and when required. Take the knowledge, take the tools possible to augment your intelligence and do more productive work than the repetitive work.
Very well mentioned when we say about the algorithm versus human excel. So, algorithm definitely there's a high volume screening, identify suitable pixel pattern, and reducing the fatigue related error, which is mentioned by Dr. Ravi. But the what is human excel at? It is contextual judgment, integrating comorbidities and ethical responsibility. That is something which is really, really important. Moving on to the fourth question, where precision medicines and the reality check. Precision medicine promises individualized care. In practical clinical settings, how close are we making this scalable and affordable? Over to you, Dr. Ravi.
I think precision medicine is definitely, it's there. It's actually now come up, taken up. It's growing very, very fast. But the problem is the scalability you ask. It's very uneven. You know, your cancer cases are projected to reach almost like 5 million annually. But when it comes to the molecular testing, is actually the core of precision medicine and therapy, companion diagnosis or target-based therapy, is still limited outside metros. Top 10, maybe 12, 15 cities, still limited, number one. At one point of time, it was very high. Next generation sequencing or PCR methodology, digital droplet PCR. Uh, it was very, very now with the volume going up, it significantly dropped certainly. But still some 25 to 1,000 rupees, which were earlier lacked, but can afford it. I think this is a challenge. Skill is always a problem. Infrastructure is a problem. CapEx is a problem. Cost sensitivity, importantly, I always say, insurance coverage. The reimbursement, this is another problem. Still, this is not taken up by various, they don't reimburse these kind of things. We have to fight them hard. We try to work on it. So, precision is definitely going to be here. A lot of support is required from all the people, whether it's the users or maybe the government reimbursement provider. It's very important. Today we talk about liquid biopsy. The word about liquid biopsy, what? If you cannot approach a tumor in the brain, if you do a surgery, probably patient will die because needle somewhere hit and died. If can we extract that mutation from the blood? Yes. There are in brain tumors and lung cancer. This liquid biopsy is playing a great role, and it's a great hope, I'm sure. Without surgery, because you're not able to identify, we're not able to reach the surgery. Because if you do a surgery, small nodule here, small nodule, which will you remove? How do you reach material? Multiple lesion, probably simple blood test can help. Maybe sometime in the future, and I'm pretty hopeful the liquid biopsy tool for preventive screening, predictive screening, which there are almost some now tests available in the country where we can work on. Target therapies, of course, are very well known. The EGFR, lung mutation, and ALK mutation, specific drugs, outcomes of change. And definitely you see survival has gone. Why? Because your chemotherapy has become almost like a daycare discipline. Mortality has gone down. Morbidity is much better because of the therapies. And this again, diagnostic is working actually behind it. And this is what drugs are defined. There's pharmacogenomics, of course. That's how pharma industry works. They can probably create more drugs, develop more drugs, more precise drugs, and rare disease something which can be identified today. They are becoming slowly and mainstream in the tertiary care. So the future precision probably is, I think, the four important faculties. One is, of course, oncology. Second is rare disease. Now it be, say, preventive genomics in urban India, and then autoimmune infection disease. This is where I think precision medicine, because you now know one sample, bacteria, fungal, viral, specifically, you know this within 48 hours, everything gets much better. That's what it is.
Amazing, very well mentioned. When you talk about scientifically, we are very close, but when it comes to economically, we are still constrained. As you mentioned very well, when it comes to precision medicine today, is concentrated on oncology, given an example of the rare diseases. However, the scalability always depend upon the cost of sequencing, insurance coverage, data infrastructures, and the physician literacy too. Moving on to the next question, diagnostics errors and the patient safety. Can AI and the digital pathology meaningfully reduce diagnostic error, or do they introduce new categories of risk? I would require your insight on this. Thank you.
Yes, I think diagnostic errors are very well known, no doubt. In fact, worldwide, the data say roughly 5 to 7% there are diagnostic errors and is accepted data everywhere. Now, there are three components to it: the pre analytical, analytical, and post analytical. That means the sample, by the time you collect it and reaches in the machine, from the machine, the report reaches the clinical action. I think these are that's post analytical or pre analytical. I think majority of the errors do happen in analytical phase, 60 to 70% of that. Analytical errors are very little because automation has happened now. A lot of controls have happened. I mean, absolutely much evolved. We hardly any like, analytical errors. But still, if you run your system well, if you overstep, you don't take some steps. Of course, errors can. Post analytical is something I'll say simple. Even a post analytical means what? If the report is done in time, but if the doctor in time, how will it treat? And he misses again an error. Because that is why the new definition has come in this. Earlier it's called TAT, turnaround time. Means the sample reaches the lab and report is used out. Now TAT, from TAT we have moved to CAT. And what is CAT? Clinical action time. Because no point in having a report which is ready with me in 2 minutes. It doesn't reach my doctor who's to treat a patient for 3 hours. So I think the monitoring, this is where I think the technology is helping us monitoring that. How fast, because everything can get integrated together. Cancer, the pap smear cytology, is all cytology. I mean, thousands of cell one has to screen. We mind you to see from microscope. But can technology actually look into it? Yes. If you have a technology use, probably number of misses will come down. At least alert will be flashed out. If this has got abnormal cell, please have a relook into it. Because fatigue sets in. Then quantification variability, I've already mentioned about it. Somebody will say 2 plus, somebody will say 3 plus, somebody will say mild dysplasia, somebody will say moderate dysplasia, somebody, no, it's just an in situ. Now, how do you work? This is all individual. I think that errors also will be reduced. But that's going to be new risk again. And what is the new risk? Because algorithm bias. This is what, because if you have not done your homework well, if you are not system validated well, biases can set in. Geographical bias. Probably you have a population where cases are much more, or somewhere hardly any cancer. How will you, if you put them separately and use? I think you need to take care of that. How you validate the algorithm? How do you build up algorithm? Data again drifting from here and there, and over reliance again a problem. Okay, human mind need we cannot be blindly overlooking it. So screening triage is very very good. Helping clinical decision very good. And alerting you is very good. Integration is very good. But I think again we have to use our actual intelligence before. So AI must assist, but not autonomously decide. Human in loop system is essential. That is what I feel. And but definitely use of technology frequently can bring down AI can bring down the errors, and even a 1% error means millions of lives will be saved. That's what.
Very well mentioned. Organizations like WHO emphasize governance and the validation before the clinical deployment. Therefore, human oversight remain non-negotiable. Very well said, Doctor. Moving to the data is the new specimen. Traditionally, tissue and the blood were the specimen. In the AI era, is data becoming the most valuable diagnostic substrate?
Exactly. I'll say the earlier specimen and today blood, tissue, urine, body fluids. Now data is again a specimen. It's a longitudinal biomarker which gives you the entire. I think data is definitely of big use, but provided it is a structured data, it's correctly uh, integrated, and it's probably like the quality, because quality data is the most important. Maybe somebody has put a wrong diagnosis, the wrong thing, and probably you will end up with the wrong diagnosis. So validated and probably integrated. And I think we all should know what is right data, what is wrong data, the correct way of writing data, what are the ways of writing format data. I think that's a lot of things happening into it. That's all probably it can help out. In fact, if it, of late we have a AI summit in Delhi, and this is where one of the top most people in the world, from US, which of course about they talked about scale gives us a massive data pool, and this is really speaking from business point of view, it's a gold mine. So much diversity, so much different environment, so much of genetic problems, so many disease. I think this is a place no one can have better data than us, provided we structure it. And I started with we have Ayushman Bharat, unique ID, everything it can be integrated in a right way, and probably but behind the quality, because you cannot have a accredited lab or maybe non-quality lab. I'm not saying accredited, but not compliant with the quality lab. They can have a wrong value or wrong report, and it can affect your entire algorithm. So the data can have a predictive rating. Now look at the diabetic part I just mentioned about it. Like it's about 80 million people in India, about almost like 100 crore people. They are actually suffering from diabetes, and there's the data which say that only about 50% of people are actually on treatment. Remaining 50%, either they are not aware or they're not even they're poorly monitored. Now, if you have a right kind of a data in front of you, you can actually save life. You can delay the onset. You can do early diagnosis. You can make sure that the infrastructure which is loaded today, because of these simple things, probably people will not reach that complication stage. So prediction muscle for diabetes, early cardiac disorders, sepsis. I mentioned sepsis is one of the common cause of mortality. Now, one simple example is like if you have the probably right kind of a data for a prescription, because prescription error is another kind of a thing. You know you what is the drug, what dose, what time is not there. What I'm trying to say is that we need to have a data right in place. And data is going to play a very important role. Over 5 years, your data is proper. You can predict next 10 years what will happen. That's a new biomarker today, and population cancer screening methodology. You can, and based on that, you can budget your funding. That's another important part. If I know in this part of the city or this geography, more number of patients would have hypertension from 2 years now, let me spend money on treatment. Why I'm spending a rare thing? I think these are all important. And especially in an era of biopsy, you can say that. And once we earlier we used to preserve tissue blocks, we still preserve that, but now time that we must preserve our data integrity and keep it intact is going to help us in the future.
Very well mentioned, doctor. When it comes to in technology companies such as Google, okay, which Google Health are building a models trained on a massive data sets. The competitive advantage in the diagnostic will not only be the lab equipment, but it will be data quality, integration, and the governance. Moving on to the smart lab and automation, I see you have an experience with an amazing building up the setups or the smart labs. What defines a future ready smart lab and how you would like to focus a light on this?
Yes, I think they say smart lab. Earlier, so you have computerized lab. That means one computer is computerized. That is not the answer. Same thing. Smart lab is ready is not with the machines. It's one which has got end to end automation. Number one, right from the sample registration to the sample, everything is automated. There's a middleware integration. There is a lot of mid between two machines speak to each other, two people, two equipment speak to each other. That's the integration. You're a lab in a hospital, they talk to each other. I think those are patient from home collection, sample collection, phlebotomy to collection to transport to the registration, then the quality and the running and validation and authentication, clinical decision, everything is integrated together. Now that means integrate your. Today I must mention you. There's still, I'm sure many of the labs ask the difference between what is LIS and what is LIMS. That means Lab Information System, Lab Information Management System. This still confused with that. I think this is what I think we need to, today. LIMS is something different, which is actually what we require. Everything integrated together. So you integrate your lab software with EMR, radiology, genomics, and use predictive outcomes. No report should say that Please correlate clinically. Please correlate clinically. You have entire technology. Or it can help you in AI assisted quality control, I mentioned to you. It can help you in predictive maintenance of equipment. Something is going wrong. It can help you in CAT monitoring from CAT, I mentioned to you, and clinical decision support system. Because reflex testing, why wait for after the clinician sees the report and a new sample comes up? You already have a sample. What is more required for early diagnosis, final diagnosis probably can help. So these are all smart tests, so we need to actually, the majority of the labs are today, in fact, there are about 20% lab, I'm sure they're integrated, but still, like, they're maybe having expensive analyzers, but they have a manual workflow bottlenecks. There's no data integration. There's no analytics happening. No patient communication layer. I think that's where I think technology, I'll say, without strategy is just a decoration. I think we need to just put technology integrated well and make sure that's this is called a smart lab. We're just not looking for automated smart lab, fully integrated. Future ready lab will be integrated, and from end to end, everybody will be talking to each other. Communication, converse, and talk and deliver. That's
True, doctor. When it comes to companies like Philips Healthcare are building integrated diagnostic ecosystem, not just device. A technologically equipped lab without strategic integration is simply automated, not an intelligent. Very well mentioned. Coming back to the decentralization and the POCT. With the rise of POCT and the home diagnostics, are we decentralizing healthcare or fragmenting diagnostic quality? Any thoughts on this?
well, I think if you look at the gap in diagnostics, huge. If you look at tier one cities, tier two cities, you can find a lot of diagnostic centers. You can have a lot of testing and the moment you step out, tier three and tier four, this is a lack of not only quality, facility even to the sample has to travel all the way. What is an answer? Answer is like, and or otherwise the cost to patient have to travel away. They probably have an instant cardiac arrest. They don't have a CT, CPK, troponin 10 instant markers are not there. How do you test that? POCT is point of care. It is definitely, a need. The India rural urban divide demands decentralization to bridge this gap. The growth is definitely growing globally almost by 10 to 15%. Now, the India is going to much faster, and it is going to be there because it helps in faster decision making. It reduces hospital burden. Patient may not require hospitalization. Probably one injection of insulin, sugar will come down, and patient is fine. They evaluate it. Otherwise, they rush to the hospital, admit for 2 days. Emergency patient is not can't take because bed is occupied. So reduce burden and a rural reach, screening, preventive, and probably take chronic disease, which is almost like 40 to 50% burden of the chronic disorder today. It can be monitored there. Monitor it well, avoid complication. The risk out here is the risk is quality variability. Today, PCTs are being used in isolation. You need to very careful while you're validating or while getting POCT. So I think there is now government is also tightening that. How do you introduce a POCT? It has to be absolutely. It should work in all conditions. High temperature because India is not like 30 degrees, almost 45 heat. Their battery doesn't work. They don't know how to store the strips and the cards. They probably store outside. It gets damaged. So the quality variability happen. Calibration issues can happen. Data is fragmented. So what solution is? Integrate all these POCTs. Central lab integration is the answer. Connectivity is also to be important. The network has to be very, very important, which is going very fast now. There's no doubt about it. And standardize the quality control protocol. Run through your POCT device, run a quality control, which is inbuilt, but do it very, very well. And do an audit trail. Whatever the document can somebody, we go for a, say, annual medical contract or conditioners or maybe even small any systems make sure. But what about your purity device? Have anybody done an written contract? Really, we don't. How do we let us integrate? Let back to a small lab nearby. This is my instrument I'm using for 3 months. Can you just validate it? Have a look into it. think the company should talk have plan. There should be external quality assurance program should be run for these control, which is inbuilt into it. But still, maybe some you're not using it well. So I think the fundamental concern is that decentralization will expand access and must expand quality. That's one. POCT will bring care closer, but standard all this is we're going to be too decentralized.
Absolutely true. The future lies in the connected decentralization, not isolating testing, as you well mentioned. Moving to the economics of innovation, how should healthcare balance a cutting edge diagnostics with sustainability?
I which I really like to say diagnostic is I don't know healthcare diagnostic is in India, no doubt about it. I think if you probably the lowest cost of diagnostics and last I think if you look at last 10 years, everything increased. Diagnostic rates, MRPs have not increased. They still remain the same, or maybe the. So I think yes, India. I still understand. In India, is a cost sensitive because is out of pocket expense happens probably, and we need to bring down the cost. A lot of innovation is required. And reimbursement model don't the quality. I mean, you can say about the quality because that's the biggest problem. Today, our insurance, health insurance is driven what? They're driven by treatment. They are driven by screening. Now, for example, today 70% or 60% patient come to a hospital with the cancer in stage 3 and stage 4, and cancer guy and the reimbursements are much higher. But if you reimburse, they invest into preventive part, which is much cheaper. In screening, maybe 3,000 rupees or 2,000 rupees annually, it can be done. Probably the percentage of people reaching from the third stage or fourth stage will come down to 40% already in the developed world. 38 to 40% people reach into stage 3, stage 4, 60%. Now look at the reimbursement, saving they have. I think that mindset need to be changed. Thought process has to change. That's one part. So we need to create, reward that model. If you're done, you will benefit. Balance innovation, sustainability, volume-based pricing, higher testing model, not do everything possible. Whatever is required, do it. One stage, two stage, three stage, algorithms, driven, system driven. Otherwise, you do everything and then you say, oh, well, this was required, nothing else. Maybe there are protocols, there are flow systems and charts, public-private partnerships, somewhere government, so expensive and private can happen. Domestic manufacturing, reagents can bring it down, and AI-driven operational efficiency. AI can actually track where we have spent more. I think that also can be. So innovation must reduce cost, not just increase complexity. If you can do that, I think we'll be able to serve the actually people who are in remotes who can't afford it, and India definitely needs that kind of thing, and it's very very important for our healthcare system.
Yes, very well mentioned. Moving to the ethics and the AI governance. As algorithm increasingly influence diagnosis, who carries accountability? The clinician, the lab, or the machine?
Well, accountability cannot be outsourced to algorithms. That's fundamental. It cannot. Responsibility hierarchy has to be clinician for clinical interpretation. Ultimately, they are the custodian of patient. They need to correlate everything. Lab for validation and quality. It's our responsibility of like whatever you're delivering from the machine is in perfectly order. Analytical or pre-analytical. Make sure and post-analytical of course. Now, developer of algorithm, person who's developing on the technologist people, bioinformatic people, it's again they should be very, very careful. Their integrity is also important. So I think these three areas, when it comes to clinical interpretation, the clinician, when it comes to lab, is the lab pathologist or diagnostic people, and the developer. I think this is where responsibility hierarchy should be. Now, India urgently needs there are now some draft has come. AI validation, software as a medical device, or AI validation frameworks are now being launched. Something has come, but still we definitely need a AI validation framework. We need still a regulatory clarity because the way the regulations are developing, the technology is leapfrogging. By the time the regulation comes and implemented technology is moved ahead, and then the regulations go behind, and then they come up and then they go behind. I think the real-time technology and regulation have to come together. Then it's important to have a transparent data set. I think why now? I mean, you can have a centralized bank of data. I think that will help. Every data machine we generated go to central pool. You pick up, pull it out from it, study, do algorithm, do your study. I think you'll get a much better and finer diagnosis. So trust will define adoption, and ultimately, you know, transparency. I probably feel will build the trust faster than technology. In healthcare, only thing which works is trust, and ultimately, the custodian of trust, the human being, the doctor, accountability definitely lies with it.
Very well mentioned. And obviously, when it comes to moving to the next question, training the next generation, what mindset shift must young pathologist and the clinician adopt to thrive in an AI-driven diagnostic landscape? Any suggestions?
This one line I'll say: the mindset shift is required from I see slides or I read slides to I design diagnostic pathways. That mindset. That's what I mentioned. Pathology is not supposed to be just behind the microscope. They have to come in front of the microscope. Go to the clinician, understand what do they want, and provide them a clinical solution, not just a value of a report. There's a value of cholesterol, a value of whatever it is. One single figure is not. Make a clinical solution to it. Redefine your designation, redefine your study accordingly. You should learn for that. What you do, young pathologists must learn data sciences basics, understand AI limitations, and then embrace interdisciplinary collaboration and think systems, not slides. And this is what the new the vertical is emerging. That's called integrated diagnostics. Today, everything has to be. And I'm sure this is already started in US and couple of institutions. They have a specialty in integrated diagnostic, and we are still, I think, far behind. But yes, technology can help us bridge the gap, and young pathologists definitely need to change their mindset by using all learning data science, AI limitations and system, and of course, adopting the tool into day-to-day practice. And of course, talking to the clinician. Make sure you're talking to the clinician and the patient together and using your own brain with the technology to arrive at the decision.
Very well mentioned when it comes to even the data literacy, AI collaboration mindset, interdisciplinary fluency, system thinking, and the ethical awareness. Because tomorrow's pathologists must understand both histology and algorithm that you already mentioned. The stethoscope of the future may well be computational. Okay, moving to the last question. The future vision, if we fast forward to diagnostics 2035, what will surprise us the most, technologically, clinically, or philosophically?
Technologically, I'll probably say AI triage of routine slide, biopsy, screening, cytology, AI triage. They will screen out. They will become a trial. Just screen out. Then real-time liquid biopsies. This is going to be that going to be a more of a predictive tool. Many have already entered, but I think probably much more adoptable the preventive screening. Then actually the cloud-based national network. Everybody has to come in the cloud. That data is all integrated together, and then probably come out with the system. The entire network is a thing. Now, clinically, predictive diagnostics before symptoms. You can because by that you have an entire life cycle of the individual. So the times is born, genetic, lifestyle, environment, some disease, family history, all together. Even before a symptom, you can predict probably this is going to be definitely. Tools are now there. They've developed very, very fast. And a personalized preventive dashboards. In the personalized medicine, because two people are not alike. Two human beings are not alike. Always variation. One 40% of people does not work well. Why? There is something somewhere wrong because of the diet, environment, sleep, habit, genetic, whatever it is, or algorithm. So I think the personalized preventive dashboard clinically going to be there. Philosophically, I think you mentioned that. Diagnostic will move from disease detection to health forecasting. The biggest surprise will be, I feel we are more moving toward transparency. We are more engagement is happening with the patient. Though they're very easy to engage now because of the technology. Doctor, clinician, care providers, nurses, everybody getting together, and interpretation is becoming more standardized. So I'll say that if you look at it, today, say the doctor orders a test report, then there is a manual interpretation, and then the treatment starts. That's it. But I think with the time, will be a patient data first. AI will do a risk analysis and engagement. Then there'll be targeted test panels, what will be done based on the entire data. There'll be integrated report. There'll be a clinician will probably now come into decision support system. They'll also be guided with that report. There'll be outcome tracking, and ultimately there'll be feedback loop again. Now, this is what has happened, and feedback has come back. So it's not just an automation; the entire ecosystem intelligence and going to be in place. I think this is what I feel as we walk in 2035.
Very well mentioned. Diagnostics will shift from detecting disease to the forecasting health trajectories. Healthcare will move from episode intervention to the continuous intelligence. Diagnostic is not being replaced by machines, it is being amplified by them. The real transformation will not be technological alone, it will be now responsibility, and intelligently we integrate those tools into the patient care. Thank you so much, Dr. Ravi, for your wonderful insights and the beautifully, you spoke about the big picture from molecules to machine, AI versus human intelligence, precision medicine's reality check, diagnostic errors and patient safety, data is new specimen, smart labs, automation, decentralization, POCT, economics of innovation, ethics, and AI governance, plus training the next generation and the future vision. Here, I move to the questions and answers. In the chat box, I see a couple of questions. The first question goes to you. Are
I
the POCT?
think, Dr. Jyoti, before I think we move to question, I like to just maybe small take home, I think
Yes.
call, and after that we can answer them.
Yeah.
I'll say that as we stand at the edge of this new era today, from molecules to machine, let us remember one. Technology is not the hero. Data is not the savior. Algorithm is not conscious. We are. That's most important. Machines may detect patterns, but only sides, hands will decide compassion. Only human minds choose responsibility. Only human hearts understand what a diagnostic truly means. The future is of diagnostics today is not about louder machines. It's about innovation for prevention. I think that's what the future. More you work. Imagine a world. I think I can say I'm a big pathologist. I always see cancer patient where cancer is found before the fear begins, where organ failure is detected before the damage spreads, and where illness is intercepted before suffering peaks. I think if you can imagine that, is very good. And this is not a science fiction. It's a science waiting for intention. Diagnostics will no longer stand behind medicine for sure. That I must say it here. It will stand at its heart. And in that future, healthcare will not merely treat disease, it will protect life. And that's the fundamental role of diagnostics. Now we can move on to questions. Thank you so much.
Very well, very well mentioned. And you being so, apt when it comes to, understanding the molecules through pathology. So, Dr. Ravi, moving on to the questions from our participants, from Kumar Abhishek, who's an XLRI alumni. He's asking, are the POCT will work in coming era?
Definitely. POCT, we have, they're growing about 20% rate in there. No. Because today the care is not in the hospital. Care is right at home. It's the transit, the travel time, primary care, preventive what, and chronic disease. A chronic disease patient is not going to come every time to the hospital for his OPD consultation. They can monitor. And there are algorithm, AI-based telemedicine, everything is happening. The POCT will be definitely need. And they are the one today they can fill the gap. There is a challenge in POCT today, but many of them are refined. And I think I definitely see there's a fundamental growth in POCT. India need to manufacture India-centric and comfortable POCT and probably validated well. And this now, of course, if you must see government validation labs for these instruments. Faster, IVD is growing very, very fast, and POCD is going to be answer fill the gap. Today, we have suitcase-based labs. You can take a scooter and go around get something done. It is already there. COVID, we in every house there is small POCD, oxygen saturation, everything was in the IL-6 and coagulation disorder, prothrombin time is already there. I think all it need to probably yes, reach there and prices need to come down, integrate them well, quality, validation, and maintenance. I think that works. We are heading for that.
Very well mentioned, Dr. Ravi. There's one more question which came to me. What role will genomics play in everyday diagnostics?
Well, genomics is entered everywhere now. Whether it's something called as a although if you look at the oncology part, not more than 7-8% cancers are hereditary or genomic driven. But yes, genomics is definitely because everything happens within our genic system. Genomics not only the cancer but also into day to day. You can say prediction your how predisposed you are to a disease, whether hypertension or a senior dementia or Alzheimer's or neurological or Parkinsonism or oncology or renal disorders, CKT, cardiac, everywhere genomics is now playing a role. We're doing cardiac mapping. Standalone genomics not. You need to have something called as risk scores. Genetics can be one part of your calculating your risk and there are multiple parameters. Your genomics, along with your biochemical testing and the blood testing, maybe radiology testing, your lifestyle, your environment, your sleep, your eating habits, and put together family history. That is where I think we create a risk score. To arrive at a risk score which is more precise, genomic going to play a definitely. Today we are missing out because probably if your family history is not actually what is inside your genes, nobody knows. I think when you have something called as people are doing something called genome patris kind of a thing from genome patri. They have all this thing. Have a fundamental ready with you. Tools are being developed now, develop personalized score. So they have reached last 15 years. I've seen it's almost reached whether it's autoimmune disorder or it's neurological disorders or it's liquid biopsies, whatever it is already reached there. And preventive, diagnostic, therapeutic, prognostic. I'll say from womb to tomb. This is going to roll. This is going to play.
Very well mentioned. Over the next decade, I believe that there's a polygenic risk coming. There's a pharmacovigilance, and the early detection of predictions definitely will help us. There is a next question from Anrit. What are the biggest barrier to the implementing AI in pathology labs today? Cost, validation, or trust?
Well, I always maintain biggest barrier is the trust because we don't know from where the content is coming, what is inside the blood, how your algorithms have been developed. This is the moment you start trusting the no validation source because when you do everything, okay, I am treating a patient or maybe in my medical education. How it's not like I read my book because there's a fundamental credible books which is for generation they are the answer. So trust is the fundamental thing. And trust will only come when you have a right validation, right kind of mindset working on it. So it's our responsibility for us, for our future generation, all of us. I will definitely say adopt AI in pathology labs, validate it using your wisdom. First, you develop trust by yourself, and then automatically the public will trust. And I think future is here. We cannot overlook it. Do it. Maybe small cost will help you in future.
Very well said. There's a last question for this podcast. Are we prepared for AI related medico legal challenges?
Well, again, I said this is a responsibility lies with clinician, and said somewhere in between. AI is artificial intelligence. I'll repeat again. AI is also actual intelligence. Without using your actual intelligence, if you're using artificial intelligence, this is not going to work. I mean, it may work, may not work, but ultimately, the actual one who has got actual intelligence, They are the people who are responsible, accountable for it. So I think you cannot get away with that. This is the reason I think AI is taking little time to get to, and especially in diagnostics. Everywhere, because this is not a life is involved. Every sample is a life, every data is like something. So we are taking time here, but responsibility, come what may, will ultimately lie with the human being, treating physician, treating doctor, nobody else.
Very well mentioned, Doctor. Our future medical legal framework must clarify the liability distributions, the algorithm validation standard, documentation of AI involvement, transparency protocol, and as you mentioned very well, the healthcare system like National Health Service are actively evaluating governing structures, managing digital transformation risk too. So here
I must
we
one line here because I think just one line because today I think I've heard, I don't know the truth, but fact is yes, lot of judiciary court judges they are using AI because so much of judgment they have to read otherwise. Everybody is now putting into AI and then it's AI. Oh, this was judgment and summary comes out. I think because there's a judgment which existed in writing and documented today. If you that is again, if your data is correct, you can trust your data. And I think if they can use it, why can't we use it? But yes, trust, do your own validation before you start using anything which is publicly available.
thank you so much, Dr. Ravi, and it's been really wonderful connecting and sharing the insight. We believe the JVATech Motivation and the Power of Knowing Forum Collaborative on the Healthcare podcast series. Today, we spoke about the future of diagnostic from molecule to machines in the new age of AI precision pathology. Your structured depth of knowledge, execution level of the mentioning about different parameters and the dimensions, and a thought leadership has definitely positioned and really well validated this particular podcast. Thank you so much, Dr. Ravi, for being with us. It's a really honor, indeed honor. Thank you so much. Thank you so much, Power of Knowing. And again, I would like to extend my sincere gratitude to all the participants for being here and present and connecting with us. Stay tuned for the next podcast too. Thank you once again.
Everyone, thank you. Bye bye.